Welcome, and thank you for joining us for today's session of Frequently Asked Questions on High-Risk Disease. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Jonathan Kaufman and Sara DiCamillo from the Winship Cancer Institute at Emory University in Atlanta, Georgia, and Steve Hoofnagle, a myeloma patient living in Atlanta, Georgia. They've agreed to answer some common questions that patients or their caregivers have about high-risk disease. Okay, so we often receive questions about high-risk multiple myeloma. Dr. Kaufman, my first question is for you. So with regard to multiple myeloma, what makes someone's disease high risk, and how does that impact their prognosis?
Okay, well, first, hello to everybody, and hi, Mary, again. High risk, in a large part, high risk disease is defined by what we call either cytogenetic or FISH abnormalities inside of the myeloma cell. And there are typical abnormalities that we see in the genetics or in the chromosomes of a myeloma cell that confer high risk. The genetic abnormalities that are typically considered high risk are deletion of the what's called 17p. That's the small part of the 17th chromosome. There are what we call translocations that are considered high risk, where translocation means a part of one chromosome is mixed and match with a part of another chromosome. So, for example, the 414, the 4 and part of the 14 are mixed and match. And so we'll say T414 or 414, and that confers high risk. There's a translocation 1416. And then some of the newer high risk features are abnormalities of the first chromosome, a gain of 1Q and a loss of 1P. Those are considered those are considered high-risk abnormalities. And just for some clarification, when I say Q, that's the larger side of the chromosome, and P is the smaller side of the chromosome. And we have this test called FISH, which basically seeks out these areas within the myeloma cells to determine if a patient has these abnormalities. And so to answer the second part of your question, what does it mean when I say high risk? And basically, when we see these high risk features, our approach, I'll step back a little bit. Our approach is to classify patients broadly into two groups: standard risk and high risk. And basically, what high risk means is that an individual patient is at higher risk for the myeloma coming back earlier after initial therapy, and higher risk of dying earlier from myeloma compared to the standard risk patient. That's the easiest way that I understand risk. And so we have some things that we do differently because a patient has high risk disease.
So this has been sort of an evolving conversation over the past number of years in the myeloma field. And I think that we're getting pretty close to consensus now as far as what actually high risk is, and then what to do about it, right? And, many of the clinical trials that are ongoing will delineate the activity of an agent in the high-risk patient population versus in the standard risk population of patients, which I think is pretty useful when if you're one of these high-risk patients. So it's sort of good to see that there's been so much attention paid to this, because it's a fairly important facet of people's disease, whether or not they're high risk, and it definitely matters. So, Sara, can a person's risk status change throughout their myeloma? So in other words, can a patient go, for example, from being a standard risk patient when they're first diagnosed to then becoming a high risk patient farther down the line, or vice versa?
Well, hi, everyone, and thanks, Mary, for having us. So for this question, as Dr. Kaufman mentioned, we like to assess risk at diagnosis early on. And when a patient is fit into the high risk category at diagnosis, they'll always be considered a high risk patient. So those patients will not transition to a standard risk situation. Conversely, on the other side, patients can have standard risk disease at diagnosis and later during relapse might develop some high risk features. So examples of this, if a patient relapses early in the first couple of years, we actually consider these patients to be functionally high risk. And also patients, when they relapse, we might do a bone marrow biopsy and see new cytogenetic abnormalities that were not present at diagnosis. And some of these Dr. Kaufman mentioned, the deletion 17p, the gain of 1q. And lastly, other things like plasma cell leukemia or extramedullary disease are other ways that patients can present with high-risk features. And again, this just tells us that the myeloma has changed to just a more aggressive form and unfortunately, usually with a poorer prognosis.
So, Dr. Kaufman, myeloma patients undergo lots of different tests to characterize and monitor their disease. And Sara just mentioned the bone marrow biopsy, which is an important part of that. So what type of testing is done to determine a patient's risk status, and how often is that repeated?
Again, I think as Sara mentioned, the most important time to understand a patient's risk is at newly diagnosed. So again, that's the bone marrow biopsy. The standard test is looking at the cytogenetics and the FISH test. And so so a bone marrow is definitely important for that. And then the other important test in high-risk patients, and probably in all patients, but particularly in high-risk patients, is to do what's called a PET scan. And what a PET scan helps us is determine for all patients whether a patient has myeloma bone disease, but in high-risk patients are more likely to what's called EM or extramedullary myeloma, meaning that we see evidence of myeloma outside of the bones and bone marrow. When we say medullary, we're talking about bones and bone marrow, and extramedullary means outside of the bone marrow. So if we saw a tumor of myeloma or a plasmacytoma in an organ, then that would be considered, or a lymph node that was full of myeloma, that would be considered extramedullary disease. And again, whether that happens early in the course or late in the course, that denotes or connotes a more aggressive or high risk myeloma.
Mm-hmm. So what is the relationship between, high risk chromosomal abnormalities and then the other laboratory values that also connote high risk, like beta-2 microglobulin or lactate dehydrogenase?
Yeah, so when the standard staging criteria for the higher stages, ISS stage 3 or revised ISS stage 3, include things like the beta-2 microglobulin. And what we're learning more and more is that the major drivers of risk are really centered on the cytogenetics, because there can be high beta-2 and high LDH driven by high risk cytogenetics, but they're somewhat non-specific, and we can see elevations of beta-2 based on kidney function. We can see elevations of LDH based on many things that aren't specifically related to myeloma. And so I think the more we put our research together, the more we're honing in on it's really the cytogenetic abnormalities that drive everything. I would say one of the challenges that we have with cytogenetics is not all laboratories are created equally. And sometimes we get we really feel like a patient has high-risk disease. They have a high LDH and they have a high beta-2 microglobulin. They have normal renal function, but we get these cytogenetic results back, and they say there's normal cytogenetics, and we know that that's probably not the case. And so in those situations where we lean on the more clinical features, the basic laboratory features that can help us determine high risk. But the hope is that all patients have access to a high quality laboratory that can give them the important cytogenetic information.
Yeah. So, and I mean, and certainly fish-based testing will take you only so far, but really like the gold standard is really more the sequencing type of testing,
Right.
right?
I
The
think
next generation sequencing for some of these patients, if they can get it.
right, and I think I think so. That's it's sort of the future is now. That's the future state, and we're there now. I would say that for the most part, our current guidelines are all based on fish-based testing, and I think the future is going to be a more sophisticated testing like next generation sequencing, as you mentioned.
Sure. So, Steve, let's talk a little bit about your patient journey. So how did you first learn that you had myeloma, like when you were diagnosed? And do you recall at what point in your journey that you were told that your myeloma was a high-risk subtype?
Certainly. Thanks for having me. I'm excited to be here. During an annual physical in 2010, I had high protein in my urine, and my primary care physician sent me to a nephrologist who saw me for about 9 months doing 24-hour urine collections and various things. And then he finally said, I'm going to send you to a hematologist, and which kind of caught me by surprise. And I went to the hematologist as part of a large group, and they diagnosed me with MGUS, monoclonal gammopathy of undetermined significance. Which really sounds scary, but that was in 2012.
A lot of big words there.
Yeah, but a doctor there at that group is a different hospital in Atlanta. He monitored me. I probably went in every 3 months for blood work, and they did bone marrow biopsies, and they also did skeletal survey X-rays. And then in 2018, 2019, he said, look, your M spike, your monoclonal protein number is getting high. We want to try and do something. So I did 6 months of chemotherapy there and before they sent me to Emory. And he did mention, the first oncologist there at the other hospital mentioned that I was high risk.
Oh, interesting. So good that he was able to refer you to some great specialists there at Emory, because they have such a really active myeloma program there with Dr. Kaufman and his friends there at Emory, colleagues. So that was a great move on your part. So important when you're newly diagnosed, and you really should be seen by somebody who's a specialist in multiple myeloma and sees lots of patients, because that will basically ensure that you're getting the most up-to-date and best standard of care when you do something like that. So let's shift gears a little bit to management of high-risk disease. So Dr. Kaufman, how do you manage patients who have high risk? Is there a standard approach to first-line treatment for high-risk patients, or does it depend on the patient's unique risk profile?
Yeah, great question. We've focused for 10 to even 15 years on using a different approach for high-risk patients, because we realized that our standard approach wasn't getting the outcomes that anybody was satisfied with. And the principle that we base this on was that we found out that our induction therapies, our initial therapies, were working the same whether the patient had standard risk or high risk. And so our approach for high risk patients is to whatever is the best available therapy as induction. That's what we've been doing. And so we've had a variety of therapies over the years using RBD or KRD. And now our approach as a standard is to use a 4-drug treatment regimen using monoclonal antibody daratumumab with RBD or KRD. Our approach has historically been RBD, very reasonable to give dara with KRD. But that's not really where we've done most of our work, because the problem wasn't getting patients into remission. The problem was keeping patients into remission. And so that's where we've had a strategy, a post-induction strategy of strong encouragement for early high-dose therapy and transplant. And then after that, an aggressive maintenance approach. And so going back, again, 10 or maybe even 15 years, we were reintroducing a RBD after transplant, and we did it in a way that was easier on the patient, weekly dosing of bortezomib, lower doses and rapidly tapering of dexamethasone, lower doses of lenalidomide or Revlimid, and planned on that 3-drug therapy for up to 3 years, followed by Revlimid maintenance.
Wow.
And then subsequently, we have investigated additional therapies. We based on clinical trial data from the Forte study that came out of Italy, we switched to carfilzomib or Kyprolis with Revlimid as part of our standard. And then our colleague, Dr. Ajay Nuka, wrote a clinical trial asking the question, can we use second generation drugs? And that was the Kyprolis or carfilzomib, pomalidomide, Pomalyst, and dexamethasone as a 3-drug regimen. And in fact, that's the study in the treatment that Mr. Hoofnagle participated in.
Oh, okay. So I think I saw, did Ajay present some of that at ASCO this past year? Yeah. So that was a great presentation.
He presented it at ASCO, and the data really looks fantastic. And now we're building on that. And so teasing out our next generation of options. We actually do, that trial is finished. We do have another trial right now using belantamab mafodotin, and we know that's no longer available commercially, but it's still available in investigation. So we have a clinical trial for high-risk patients with belantamab given every 8 weeks, so really spread out to decrease the risk of the ocular toxicity, the eye toxicity with pomalidomide and dexamethasone. But the principle is optimal induction therapy, early transplant, something different, more than standard in maintenance. And I think we're going to continue down that path.
Yeah, so that's great. So you guys are really on board with fairly aggressive maintenance therapy. I think that you sort of characterize it as that based on comparing like what other centers may be doing. So and whatever works, right? So as long as it's not too toxic on patients.
Right. So. Yeah. I mean, I think it's a major part of what we do. I mean, I think there's some people who I think Revlimid is a very good agent for maintenance therapy. I just don't think it's enough as a single agent for patients with high-risk disease. Agree.
And like you said, the important part is getting them into into a remission phase and then keeping them there, right?
That's right.
So, and giving a more aggressive therapy probably has a better chance of keeping them there longer, especially if they're a high-risk patient.
That's been our approach.
Yeah, that makes sense. So speaking of adverse events, Sara, for patients with high-risk disease, so do you have to approach the management of patients with high-risk disease who may be receiving a more aggressive therapy, 4 drugs at induction and then 3 drugs at maintenance? Do you see more adverse events when you're treating high-risk patients in this more aggressive manner?
So it's definitely quite possible when a patient is on more drugs that we may potentially see more adverse effects. But no, in general, I would say that our standard risk patients and our high risk patients both have the potential for adverse effects. And the high risk features by themselves do not cause the adverse effects. So that being said, it is true that patients that have a higher disease burden and start treatment, we may see more side effects or adverse effects in these patients. And some of those patients are high risk, but not all of them. And so it's definitely not a cause. And either way with patients, when we monitor patients very often and speak a lot about those side effects and try to manage them with the goal to have patients continue therapy and get the best response from the treatment that they can.
Yeah, that makes perfect sense. So, Dr. Kaufman, we talked a little bit about patients who may start off at diagnosis as being a standard risk patient and then maybe progress to being a higher risk patient later in their disease. So how is their treatment managed differently once that sort of transition occurs to a higher risk state?
Again, Sara had mentioned that this concept of functional high risk, we consider patients who have progression within 2 to 2.5 years of diagnosis to be considered functionally high risk. So one of the things we have, as you know, is we have the MyDrug study that's available for those patients, and that study looks at these functional high risk patients and asks the question: is there some sort of specific molecular abnormality that we didn't identify on the FISH testing that would have clued us in that you're high risk, and see if we can target those? So that's one option. But I think if we identify a patient as high risk, it's not necessarily I would choose a different drug, but there might be some management decisions I would do differently. For example, patients who have standard risk disease can often have evidence of progression, the return of the monoclonal protein, and we'll often observe that, keep an eye on that still. And from the time of recurrence of the protein until somebody needs treatment can often be 6 months, 9 months, a year or more. With high-risk patients, people have high-risk features, I'm much less likely to observe, because I think that period of observation is likely to be very short and could be associated with rapid and very symptoms. And so it's not necessarily the treatment, more of the treatment strategy of really trying to stay on top. And again, for the most, more than anything, patients with high-risk disease really need those deep remissions to stay in remission for a long time.
So is MRD testing part of the way that you follow these patients, especially at certain time points in their therapy?
Yeah, certainly. We're in patients newly diagnosed patients and who are planning for a transplant, we check MRD before transplant, after transplant, and then yearly from there.
Yearly, okay. So Sara, we talked a little bit about transplant and how that's a big part of, early transplant is a big part of standard of care, especially for patients with high risk disease. So that is part of what you guys do at Emory, right? Is encourage people to even high risk patients, especially high risk patients, to undergo an early transplant.
Yes, exactly. As you know, and as Dr. Kaufman mentioned, that is standard of care for us here at Emory. And there's a lot of different opinions around the world about transplant and standard risk versus high risk. But I think with the data that we have now, most people would agree that particularly in the high risk population that we will proceed with the transplant.
Yeah. So Steve, let's talk about your situation. So you had a transplant about 4 years ago. So tell us how that went.
It was 4 years and 7 days that I got out. So,
not that you're counting.
Congrats.
Facebook memories. August 19th, I went of 2019. Following 6 months of chemo at the other hospital, there was about 6 weeks, maybe 4 or 5 weeks of pre-test clearances and so forth, and I had to get a trifusion central line put in and so forth. But I was in a little bit longer because unfortunately I got a little bit of C. diff while I was in there. But the procedure, I found everything. All the hemopheresis for the collection and all. You just had to go in there, and the people took great care of you. So 17 days that I was in there, and then I was on kind of like a home recovery for about 5 weeks after that, and would come in for labs. But overall, as scary as it might sound, it's really not. You just take it one day at a time, and these people are professionals and they know what they're doing.
Okay, so let's see. So I think, Dr. Kaufman, we talked a little bit about maintenance treatment in the high risk setting, and that you guys really take a much more aggressive approach to maintenance with patients who are high risk. So I know that we talked about you were using DARA along with the 3-drug regimen for induction, but is there DARA involved in maintenance of high risk patients as well?
Very timely question. And I would just say historically, we haven't. we have gone with the combination, again, proteasome inhibitor, that's the Velcade, Kyprolis, with immunomodulatory drug, Revlimid, Pomalyst approach. And in looking at our data, we still see patients not doing, certain subsets of patients not doing as well as we'd like. And so we're currently talking about designing strategies to reintroduce daratumumab or back into the maintenance approach, and seeing if we can turn that subset around that's still not doing, getting as much benefit as we'd like out of these treatments.
Yeah, that makes sense. So, I mean, and if you were going to, so that would probably be putting these patients into more of a clinical trial setting, right? If you were going to put them on Darzalex along with a number of other therapies in the maintenance setting.
Well, we don't, I mean, like I said, we have other clinical trials. We don't have a clinical trial for that approach right now, but that would more be a treatment practice, a practice pattern, as opposed to a specific clinical trial.
Got it. So then what are some of the really interesting trials that you have ongoing for high-risk patients?
Well, the trial that I mentioned before for maintenance therapy uses the belantamab mafodotin with pomalidomide and dexamethasone. We had a recent trial that I think is a great idea and I think should be explored further, using for patients who failed to achieve a major response after transplant, sort of this concept of functional high risk, to do early CAR T cell therapy for those patients. I think that's a great idea. I think we don't have a trial open like this, but the concept of whether it's early CAR T cell therapy or early bispecific therapy is something that we're very interested in. And in fact, we had a meeting this morning where we're designing a whole comprehensive trial of really introducing all of these new therapies earlier. And our approach is to do this for both high risk and standard risk patients. And we think that the high risk patients really might benefit from pulling these drugs that we currently use very late to much earlier in the course.
Right. Yeah. I mean, actually, I was just going back through my slides that I had taken pictures of at ASCO, and that's where they had that amazing presentation about the CARTITUDE-4 trial using CAR T very early, right after like second relapse or something like that, right? So that data was just so amazing, and it was just shocking that it was so effective. So
Right.
And I'm sure that we'll be seeing more of that as the pharmaceutical companies are trying to now get these CAR Ts approved for this newer indication, like in earlier lines, right? So we should be seeing that. We might even see one of those approvals this year, right? If not early next. So.
I'm not in the know.
Neither am I. All I can say is what I've heard. So. Okay, so Steve, you were in the clinical trial to treat your high-risk myeloma. And can you tell us a little bit about that? So what was your treatment and how long were you in that trial?
Certainly. So as Dr. Kaufman mentioned, I was in the trial that used the Pomalyst and the Kyprolis and dexamethasone. So I did a 36 cycle, 28 days per cycle. So you would go in three times on Thursdays, and I would have the infusions, and then I got 7 days off for kind of a recovery. So that started back November 25th of 2019 and wrapped up this past October. So again, probably the biggest thing that I didn't enjoy was the dexamethasone, and I don't think any of my friends and family did either. I was getting big doses at the beginning, and they would call them Roy Rage Thursdays. So but they reduced that for me.
I don't think anybody likes that drug. Really, it's terrible. So many people complain about it. It's awful. Although finally, I have seen some clinical trial data where they've been trying to really either like really reduce the dosage of dexamethasone or eliminate it entirely with people who are, especially those who are like more elderly and more frail, because those are the people that I think really have the adverse events having to do with dexamethasone. So we'll see what happens with that. I mean, it is a good drug and it certainly is helpful in myeloma. But if it can be managed better, I think everybody would be much happier, and families would also be much happier.
Caregivers too. They had to put up with me for 36 months.
That's what I'm saying. Yeah, right. So it can be hard. So, okay. So Dr. Kaufman, I think we talked a little bit already about the newer myeloma treatments like CAR T therapy and bispecifics. And so can you give us a little summary of how effective these types of treatments are for patients who have high risk disease versus some of the other standard of care therapies?
So, the newer therapies, bispecifics and CAR T cells, are also effective in patients with high risk disease. I think that similar to what we've seen with all of myeloma, there is probably a little bit lower overall response, but it's still much better than anything else that's out there. And always the concern for for the shorter duration of response. And so having said that, the key features that we've seen associated with, I would say, lack of benefit is the burden of disease, certainly burden of disease associated with more side effects at the time of bispecific therapy and CAR T cell therapy. And so one of the things that we've started moving towards, because right now they're all fourth line, is not waiting for the patient to have fourth line and maximal amount of disease, but really trying to identify fourth line therapy very early and try to treat at a lower disease level, which I think is probably more important, especially from a toxicity perspective, than the specific cytogenetic abnormalities. In a large part, once a patient has had 4 or 5 lines of therapy, there's a lower difference between somebody who has a cytogenetic abnormality and somebody who does not have a cytogenetic abnormality.
So there's also, excuse me, the issue of sequencing of these therapies, right? Which is an area of very active investigation right now, and also combinations with some of these therapies, right? Even combinations with CAR T, and certainly we saw some really interesting data at ASCO combining two different bispecific antibodies with different targets, which was quite interesting, that TRIM2 study. So, okay. So, Sara, what sort of ongoing monitoring is done for patients with high-risk disease? And is that really different for compared to what you might do for monitoring for patients that have standard risk?
So I would say largely this looks very similar, Mary. So for most patients, as Dr. Hoofnagle mentioned, or Mr. Hoofnagle mentioned, I'm sorry, they come in monthly, they have labs, we go over their chemistries, their blood counts, how they're feeling, anything that's changed. And this is really the part of my job that I love. We get to know patients and their families well. We get to know what's normal for them and not normal. And so we can monitor anything that's new or concerning. In addition, and Dr. Kaufman talked about this, we do bone marrow biopsies yearly with an MRD test. And then particularly in patients that have extramedullary disease, it would be a little different. They would have more regular scans just because of how their disease presents. But I would say largely it's similar. There might be a few differences in just follow-up as well. We might let a patient that has standard risk that's in a complete remission go a little bit longer between labs and visits. And just because we know the history of how high-risk disease presents, we make sure we see those patients routinely.
So do you have frequent conversations with your patients about how their therapies are going, whether or not they might want to back off on some things or potentially take a drug holiday, right? We've had a couple of recent programs where we've talked to patients who have been a little bit adamant about that with their care teams. And, once they get into a remission phase, then many of them just want to stop treatment for a period of time while being closely monitored, obviously, until they begin to have like a biochemical relapse or something. So, which is probably not what you would recommend to a patient that has high risk disease, right?
Yes. So in general, I would agree. We don't really recommend stopping treatment for a long period of time. Of course, if a patient wants to travel or be gone and miss a treatment here or there, that's fine. But we wouldn't recommend just stopping treatment entirely. And a lot of patients ask that question. If they're in a remission, can they just stop? And as we know, because the disease can come back and come back aggressively, obviously that's not our goal. And so we do encourage treatment. And to answer your first part of your question, yes. So I tell patients, the purpose of that monthly visit and seeing patients often is we want to know that the medication's working and that patients are tolerating it. So I don't think we're doing our job well unless we're doing both. And so I tell patients, I have some patients that are reluctant to tell me how they're feeling and they think they're complaining. And I remind them, you're not complaining. This is what we're here for. So we want to hear how patients are doing, and we can dose adjust medicines, as you mentioned, if needed, or decrease dexamethasone as needed. And so, yes, so a big part of that monthly monitoring and knowing patients well is being able to adjust medicines and the goal to allow these patients to live their life fully still while still being on treatment that hopefully keeps them in a remission.
Right. So, I mean, that level of communication between like the care team and the patient is so vitally important to make sure that, if the patient is experiencing a side effect and they don't tell the care team about it, then there really isn't, the care team can't really help with whatever is happening with them, right? So it's really vitally important. And like you mentioned, it's not complaining. It's just saying, okay, I'm taking this drug and here's the things that I'm feeling. Can you help me? Because it's really impacting my quality of life, right? So that's an important point. So Steve, we already talked about the fact that you're in your maintenance therapy phase now of your treatment. So can you tell us a little bit about your, like, what's happening with you, what ongoing monitoring you're having, the testing that you do, and how does that impact your quality of life? And do you find that scheduling of like the dosing and then the testing, is that manageable for you?
Yeah, so anybody that lives in the Atlanta area knows it takes an hour to get to Atlanta from Atlanta anywhere, and the traffic.
That's the truth. The traffic there is terrible.
That was a big part of it, and we've actually relaxed me to only coming in every 2 months now.
Oh wow!
And I do the blood work and also get Hep block in my port. I still have my port, but I'm on the 2 milligram Pomalyst, the 21 days on, 7 days off. I come in for blood work. My next visit in October, we're doing my annual bone marrow biopsy and MRD testing. But during the clinical trial, we did a lot of other things, echocardiograms and skeletal surveys that we're not going to do on a routine basis now. But it's very manageable for me. It's been a good experience. And I'm very grateful for the healthcare professionals there at Emory.
Yeah, so you're in a good spot, that's for sure. So, okay, so let's move on now to some final thoughts. Okay, so I've got some final questions for everyone. So Steve, we're going to start with you. I know you talked about, we're going to talk a little bit about side effects. So you already mentioned that you were having some issues with dexamethasone, right? But were there any other side effects that you had from any of the other medications that you were taking, and how did you manage that?
No, I really didn't seem to feel any. There's other patients that were in the infusion areas that had to be treated for nausea and things like that. I didn't really have any of those problems, and my kidney function has been outstanding. We're still doing a quarterly urine collection for me because I still see the nephrologist, and he likes that information. So.
I guess that's a good outcome, considering that you're a high risk patient, that you're taking this fairly aggressive treatment, and you're managing to have a decent quality of life with that, which is great. So as long as you don't have to drive into from Atlanta to Atlanta for an hour.
Yes, ma'am.
So, Sarah, how do a patient's comorbidities, so like other conditions, that other medical conditions that they may have alongside their myeloma, how does that factor into their management when it comes to high risk disease? So, for example, how would you treat a high risk patient with severe kidney disease?
So it's a good question. So we think a lot about which medicines we're using and how they're metabolized and cleared. And so in particularly, so for an example, in induction therapy, Dr. Kaufman mentioned that we usually use daratumumab in combination with Revlimid, Velcade, and dexamethasone. And so in a patient that presents with severe kidney dysfunction, we would not want to use the Revlimid. And so we would start the patient on Dara-Vel Dex, or we could use thalidomide, which is in the same drug class, but actually we don't have to renally dose. And so it's much safer for those patients, and patients still have a great response. And then if hopefully the kidney function improves and stabilizes, then we can transition these patients to Revlimid. Mm-hmm. And there's other drugs too, talking about Kyprolis, can cause heart toxicity. So in a patient that might have some underlying cardiac issues, we might try to use a different drug or monitor them more closely, and things like that. So we're always thinking about those underlying comorbidities and how to monitor closely to make sure that, again, we're not harming the patient.
Yeah, I mean, it can be kind of complicated, right? Because these patients are taking so many drugs at the same time, right? And then plus they may have some other unrelated conditions that they're taking drugs for that as well. So there's always a chance for these things to sort of interact with each other. So one final question for you, Dr. Kaufman, is what are the goals of treatment for a patient with high-risk disease? And is MRD negativity achievable for these patients?
Yeah. So the short-term goal for high-risk patients as well as standard-risk patients, particularly if they're symptomatic, is to decrease the tumor burden, myeloma burden enough to get rid of the symptoms, bone pain, kidney dysfunction, anemia, fatigue, and those types of things. And oftentimes a patient who feels very bad, even though we're giving them drugs that has a laundry list of potential side effects, a month later feels better. Now, a lot of patients don't necessarily feel bad, or if they're diagnosed because their numbers are rising. And so our goals are to really get a deep remission and have that deep remission last as long as possible. So our goal is to find the therapy, the treatment, and again, that has the highest chance of MRD negativity. And so we don't know if we're going to get there, but we want to give the patients, especially high-risk patients, the highest chance of that MRD negativity. And that's why we recommend all those aggressive therapies back to back to back, because it's by achieving MRD negativity with this treatment, that's associated with staying in remission longer. And absolutely, high-risk patients can have MRD negativity and can stay in remission for a long time. And we're seeing a patient right here who's in that boat.
Yeah. So, I mean, I think we're still dealing with about 25% of patients, 20 to 25% that are sort of in that high risk disease boat, right? Right. And for a long time, there just wasn't any way to really, treat these patients in a way that really prolonged their life in a manner where the standard risk patients were actually achieving better survival. But now there's so much research and clinical trials really focused on this issue that I think it really gives patients who may be diagnosed as being high-risk patients when they're newly diagnosed, really they have a lot of things to look forward to now. And survival is really increasing for these patients based on some of these newer drugs and newer combinations of drugs. So I think that will only get better for these patients as time goes on, which is really a great thing.
And I think
they are the ones that have the most unmet need.
Right. And I think you mentioned the key is that we have clinical trials specifically designed for high-risk patients. Historically, we gave the same thing to everybody, and then the high-risk patients didn't do as well. And then we said, well, the high-risk patients don't do well with this treatment. So we've moved away from that, and we're doing this at our center. We're doing this within cooperative groups. We're the French are doing this, designing specific clinical trials for high-risk patients, asking specific questions, and then advancing the field from there.
Yeah. So, and I think that from the data that I've seen at some of these meetings, we are having some success in treating patients who have certain chromosomal abnormalities, although the 1q amplification continues to be one of the tougher ones, right? So there still need to do some work there. So I'd like to thank our guests today, Dr. Kaufman and Sara DiCamillo and Steve Hoofnagle, for being with us today on this live stream. I'd like to thank everyone who took time out of their day to watch today. Finally, I'd like to thank our sponsors, Adaptive Biotechnology, Baxter, BMS, Cure, GSK, Janssen, Karyopharm, Regeneron, Sanofi, and Takeda Oncology for supporting this session. If you have any additional questions about what you heard on today's session, please don't hesitate to call our MMRF Patient Navigation Center. Their number is 1-888-841-6673. Thank you and have a great rest of your day.
Thank you. Thank you, Mary.
Thank you.
Bye. Thank you.